Welcome to The Scope with Dr. K, where together we can reimagine GI care.
Welcome to The Scope with Dr. K. I'm Dr. Kosinski. We're going to open the show today, as we always do, by stating that the goal of this series is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. In this podcast, we are focusing again on the provider space. Our guest today is a leader of one of the most prestigious GI practices in the country, MNGI Digestive Care, previously known as Minnesota Gastroenterology. We're bringing them on today in conjunction with the implementation of a value-based agreement between SonarMD, MNGI, and Blue Cross Blue Shield of Minnesota, which will allow Sonar to deploy its platform into what we feel will be an ideal and unique environment for value-based care. Our representative from MNGI today is Dr. Scott Ketover. Scott is a longtime friend of mine and is the president of MNGI. Unlike most practices, MNGI has created an expert IBD team, which brings the same level of expertise to a private practice setting as you would find in an academic medical center. It's also perfect for value-based care. Welcome to the show, Scott.
Well, thank you, Larry. I'm glad to be here.
Well, we're honored to have you. This should be an interesting podcast. Give us a short history of MNGI. How did you get to what you are today?
Sure. When I joined the practice in 1994, the precursor to MNGI was a group in Minneapolis, and I was the 16th gastroenterologist to join. Within 3 years, that group that I joined merged with two groups in St. Paul. And that came about because one of the hospitals in St. Paul wanted to employ 5 gastroenterologists. And they approached both of those separate groups in St. Paul and said, "We like all you guys, but we'll take the first 5 that want to sign a contract." And so in response to that, the two St. Paul groups said, "We don't want to be employed, and let's get together with the Minneapolis group and see if we can do something to grow ourselves rather than grow the hospital." And so in 96, 97, MNGI was formed. At that time, we called ourselves Minnesota Gastro or MNGI, and over time, our name and logo has evolved, and we're MNGI Digestive Health. We've grown from that group of approximately 30 physicians back in the late 90s now to over 90 gastroenterologists and 30 some odd APPs, as well as multiple anesthesiologists and CRNAs. We have 8 clinical sites, currently have 7 ASCs, and we are geographically spread around the Twin Cities of Minneapolis and St. Paul.
That's an impressive footprint you have. So where's MNGI going? We hear about all the other practices around the country. Some of them are selling to private equity groups, and some of them are getting purchased by hospitals. What do you see as the future vision of where MNGI is going?
Yeah, I'll give you a little bit more background before I answer your question. In that, turns out that the Twin Cities is sort of the home of large, independent subspecialty groups. And this may have grown out of the HMO movement in the late 80s and the development of HMOs. But, there's a lot of large subspecialty groups here, pulmonary medicine, cardiology, nephrology, neurology, subspecialty surgical groups. The colorectal surgery group here has about a dozen doctors in it, and they're an independent group. And so in this community, we have a lot of large groups that tend to support each other through, collegial medical activities. We know who all the referring docs are, and when patients need to be seen by others, we know who to refer them to. And so we've had a very stable medical environment for a long time. There are a couple of closed systems in town, which we don't necessarily work with, where the medical staff is fully employed. The hospitals that we service, 9 adult hospitals and 2 pediatric hospitals, are all have partially employed staff, but not fully employed or closed system staff. And so a few years ago, at the beginning of the private equity bubble or bulge, I should say, it's not a bubble, but a bulge, we spent a lot of time doing a deep dive and asking ourselves the question, should we be going to market as a potential private equity platform with an MSO? And we realized that, at least in our current geography, we didn't see a lot of upside for us in doing that in terms of the clinical care that we deliver. So we elected not to pursue a financial partner, but rather to continue to grow our clinical service lines and develop new service lines within MNGI itself. Our vision is to keep expanding, most likely in concentric circles from the mothership. And one of the things we did early on in MNGI is we centralized a tremendous amount of services. So we really do have an MSO that centralizes all of our scheduling and office operations and revenue cycle, as well as our clinical non-patient facing staff, all work out of a centralized location and serve all the different locations. And so that's enabled us to grow more quickly because we can develop and deliver a uniform clinical product to the patients that we serve.
Well, I remember back when we put together IGG back 2010, one of the first things I did was make a field trip up to MNGI to get a good idea as to what a truly integrated practice should look like. And I was very impressed then. I don't think there are many GI practices around the country that are as mature and sophisticated as MNGI is. You ought to be very proud of what you have built there. Let's go into a discussion about MNGI and how you approach inflammatory bowel disease. You know, most of the practices that we see around the country really don't create a specialty team inside their practice to deal with inflammatory bowel disease, but MNGI has taken a different route. Can you describe to us how inflammatory bowel disease is organized and treated at MNGI?
Sure. I think this is an outgrowth of our sort of centralized, hub and spoke operational process. So we had developed what we called a clinical practice committee many years ago. And that committee would meet monthly to look at what was happening in terms of guidelines and therapeutic options for treatments, whether it be for inflammatory bowel disease or other things, and would make recommendations to the practice at large as to how we should address, common problems and do it according to published guidelines. And out of that clinical practice committee, as it matured, we started to have physicians say that they wanted to spend more of their time in a subspecialty environment. And so we developed at the same time, a hepatology and an inflammatory bowel disease focus group. So they're subcommittees of our clinical practice committee. And we invited physicians from across the practice to participate. Now, everybody in MNGI treats inflammatory bowel disease. So we all have Crohn's and ulcerative colitis patients. However, we have a core group of physicians and APPs who want to spend at least half of their clinical time working with IBD patients. And so their commitment, that individual commitment, is that they're going to stay on the leading edge of what's changing in IBD diagnosis and therapy and management and educate the rest of us. So they commit to meeting as a group, discussing, having case discussions, also looking at the literature, also looking at what new guidelines or what new opportunities are out there, and also committing to, on an individual basis, to make sure that they stay on top of the literature and attend IBD meetings. So what they have become is essentially a mini academic department within our practice. And so the rest of us who are not part of the IBD group, we see IBD patients, but when we reach our limit of our capabilities and we would feel that we want to refer them to somebody who has both a deeper and broader knowledge base than I do, and particularly patients that are struggling with whatever therapy they've been using, then we will internally refer them to the IBD group. And they will either hold those patients and manage them directly or do sort of an internal consult and send the patient back to us to continue to manage. So it's been a great resource for us And I will say my colleagues who are in this group, they are phenomenal. In fact, most recently, as a result of what they learned about the psychosocial aspects of inflammatory bowel disease and the discussion around mental health issues for IBD, we literally in the last few months hired a GI health psychologist who is starting to see patients who have chronic GI illness and have difficulty with coping with their management with their disease.
Well, that's going to be a big help to us in the deployment of Sonar into MNGI. So tell me more about the infrastructure. You mentioned that you have physicians who have committed to spending 50% of their practice time in IBD, and they keep themselves up with the literature. And I would imagine that guidelines and protocols and pathways are pretty much ingrained in the care that's performed and provided at MNGI. But what other type of infrastructure is necessary? What kind of nursing infrastructure, infusion center infrastructure? What else do you have there?
So, and one of the things that we do with this clinic is when the IBD clinic meets, at least pre-COVID, they would meet as 2 or 3 people from the team in the same physical clinic seeing patients at the same time. So it also gave them the opportunity to collaborate real time with patient challenges. With respect to infusions, that has become a big part of our IBD practice. We have grown from 1 or 2 sites that offer infusion to now half a dozen of our sites offer infusions daily. We tend to have 5 or 6 infusion patients at a time who visit us, and we have nurses who have specialized in taking care of the infusion patients from when they enter the facility, to their IV placement, to their medication delivery, and to making sure that they have a safe and comfortable experience when they're here for their medication infusion.
Do any of your nurse practitioners or physician assistants specialize in IBD?
Yes, they do. I'd say that about 1/3 of them are involved in the IBD clinic.
Interesting. So many practices around the country really have eliminated a lot of that, and their nurse practitioners go to the hospital, but really don't have clinic experience or clinic responsibilities for IBD. So you really do have a multi-tiered, multi-level clinical team that's deployed for this. I'm going to take a little break here. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Dr. Scott Ketover, the president of MNGI Digestive Health. Let's talk about MNGI and value-based care. What does value-based care consist of at MNGI? What kind of programs are you participating in?
Yeah, good question, Larry. So over the last 7 or 8 years, the value-based care program that we developed internally was really focused around a pay one price program for outpatient colonoscopy and upper endoscopy. And we brought that to the payers about 10 years ago, this concept that instead of being billed a la carte for the anesthesia services, the professional services of the gastroenterologist, the pathology lab, the pathology reading and interpretation, the ASC facility fee, all of those individual billings, we put it together in one bundle and had one price to cover that, irrespective of whether we took biopsies or removed polyps or we spent 45 minutes with a patient or what have you. We had one set price. And we brought that to the payers, and they were very excited by the concept, but they couldn't execute on it. It didn't fit their model at the time. So what we did with that and the help of an insurance broker is we took that concept to several local employers, small to mid-sized companies where they're self-insured. And the insurance broker was able to show the employer, based upon their previous year, what they paid to, let's say, for outpatient colonoscopies in total, what they would have saved if all of those patients had come through MNGI instead of going to multiple different places. And as a result, we have contracts with several different employers where they will, when a patient needs a colonoscopy or an upper endoscopy, direct them to us. Now, they're not practicing medicine on the employer side. The patient still has an option to use their insurance wherever they want to, but the employer will tell their employee, if you use the pay one price program at MNGI, there will be no associated copay. And so the employer waives the copay for the patient, knowing that overall the total cost of care is way less than if the patient went elsewhere.
So these aren't billed through the insurance company then, they're billed separately?
Correct. They're billed directly between MNGI and the employer. The insurance companies don't like it because for the most part, they don't have the data. It's a carve out really from their existing line of service and what they provide to the employer in terms of their program. But we felt we give them adequate opportunity to participate, and they just weren't ready. Now I'll spin that forward and say with Sonar MD, and we're thrilled to be participating in Sonar. That brings a whole new flavor to value-based care for us, an opportunity to really deliver a higher level of service for overall less total cost to the system and keep patients healthier.
And get paid for it.
And get paid for it.
And That's get right. paid for it, which is the key here. You know, I'm really impressed with what you did with that bundled payment program for colonoscopy. Across the country, the same reaction you have experienced from your plans is typical across the country. The insurance plans appear capable of billing the claims, but they're really not either interested or capable of bundling all those charges into a single payment. And yet it makes so much sense for a patient going through it, even from the physician performing these procedures to have a single payment like that, and to get steerage from your employers. That's really where the value comes to the practice, because you get to continue to grow. You know, I know you're involved heavily in ACOs, in accountable care organizations. And we hear across the country that most of the plans are pushing a lot of their risk off to these ACOs. Tell me about your experience with ACOs up there in the Twin Cities. How are your relationships structured with your ACOs?
I will say that after working in an ACO model, and I don't mean for patient care, but just with a health system trying to have a clinically integrated network that could deliver as an accountable care organization. Having done that for close to 12 years, we've put a lot in, meaning we have as providers, as has the hospital system, and there's been very minimal output. This is really a result of our local market. Most of our payers are still tax exempt, not-for-profits. And as such, they're very, very conservative in looking at new models of care delivery. And so we had an early start in forming an ACO, but we've, over this length of time, have not achieved much in terms of at-risk contracting, both on the positive and negative side. We've had some, but clearly not enough to really move the needle. We hope that that's going to change in the future.
You know, I know Minnesota is a little different because your plans have to be not-for-profit, correct?
Well, that was until about 3 years ago.
Oh,
3 or 4 years ago, the state legislature overturned a 40-year-old law that prior to that time said all HMOs have to be not-for-profit. They did away with that law. So now that's how United Healthcare came into our market, and Cigna and Aetna and WellPoint and others. Prior to that time, we didn't have any of the big national carriers.
I see. So in your ACOs, you're still basically paid discounted fee for service.
That's correct.
Okay. The primary cares may be on some type of a capitated basis, but from a specialty point of view, it's still fee for service. Okay.
That's right.
Boy, we've got a long way to go with our ACOs. Moving on a little further to value-based care, let's try to tie together now value-based care with what you're doing in IBD at MNGI. And, so if we look at what you've created there, I would think that MNGI would be positioned very well to deploy cost mitigation strategies for IBD. Have you done any work to be able to tell how cost effective your care is for IBD?
We have not. And I think part of the reason we haven't been able to structure a project internally to do that is we're trying to prove a negative. We're trying to say that because of the way we deliver care, fewer of our patients wind up in the emergency department, fewer of our patients get emergency CT scans, fewer IBD patients wind up admitted to the hospital with acute flares, and fewer patients need surgery. Now, we all feel anecdotally that's true, and we've seen the change amongst our patient population over the last 2 decades, that we think we're doing a much better job, but we don't have access to that data on a total cost of care for IBD basis for these patients. So we can demonstrate what we do on our side, but we think we're saving the system a lot of money, but we don't have access to the data that actually proves that.
Well, that brings up Sonar. That will be different in the relationship that we're building between Sonar, MNGI, and Blue Cross Blue Shield of Minnesota, because we will have access to claims data that will tell us what we're doing and whether what we're deploying is making a difference. I've been very, very anxious to deploy this project at MNGI because of the structure you have in your IBD service line. Sonar believes very strongly that we need to never disintermediate the care that the physicians are providing, that we are an adjunct to that care. And one of the weaknesses that we face all the time is that we can only move things as far forward as the providers are capable of doing. But you have a tremendous electronic health record at MNGI. You use NextGen. You still use NextGen?
Yes, we do.
Yes,
Yeah.
you do. And so that's an incredibly mineable database. And now with our partnership with Blue Cross, we will have much more knowledge of how costs are being affected with the care we're providing up there. Scott, we had over 1,000 patients enrolled in the Sonar platform within a month of the deployment at MNGI. And although Sonar can take some credit for that, it also reflects the fact that you have very engaged patients up at MNGI. And so hopefully we have all the essential pieces in place. So how do you think the Sonar platform is going to impact the care you provide IBD up at MNGI?
Yeah, I think we're excited to really see the data, the at least the economic data that supports, the utilization of the tool. Well, the tool is an empowerment, right? The Sonar tool really empowers the patient and the provider to work together in a much more organized way than, as you've said in the past, for us to wait for the patients to call us and tell us they're having a problem. And so I anticipate that as we continue to enroll patients in Sonar and we start to see where the data goes, that we're going to be able to show that these patients are actually clinically doing quite well, and that we are saving a lot of dollars from the payer to the benefit of the payer community, but ultimately to the benefit of everybody.
Scott, I realize it's only 3 months or so that we've been working together on this with MNGI, but what kind of feedback have you received from your IBD physicians and your nurses in their experience working with us at Sonar?
Yeah, the feedback has been very positive. The providers, when they get an an inbox task that has been identified through the SONAR program as a patient who may be starting to flare or has some issues or needs some attention. It's incredible that the provider gets to contact that patient right away and is reaching out to the patient and basically saying, hey, I'm concerned, tell me what's going on. And that relationship, that physician-patient or provider-patient relationship is the reason that we went into clinical medicine. You know, we like to talk about guidelines, we like to talk about data, but when you come right down to it, as physicians, we deal with one patient at a time, the patient that's right in front of us. And that relationship is very, very important in both directions. And I think SONAR is a great way to help us enhance that.
It certainly should augment our ability to really perform population health along with MNGI. Well, we're very, very interested and excited in what's coming for us. I think we're almost one quarter. No, we are one quarter into our experience. So we should be having some data very soon to be able to look at where we are in a baseline, and we're going to be getting data on an ongoing basis going forward. So we should be able to continue to mold and shape our platform with you. Scott, I really, really appreciate you coming on today. We are all at SONAR looking forward to this relationship continuing to grow.
And thank you for having me, Larry. I appreciate you putting the time in to do this podcast and inviting me to be a guest.
You've been a great guest. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to our conversation on Twitter at HCNowRadio. Finally, be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.
Thanks for listening. I'm Dr. K. Tune in with me next time to reimagine the scope of GI care. If we build it, they will join.